Okay.
You're good.
Okay, thank you. Okay. Hi, everybody. I'm Linda. I'm a physical therapist here at Women's Advantage, and today we have the pleasure of talking to Dr. Leia Rispoli, who is a pain management doc out in Marina Del Rey, as well as you're with Cedars as well, correct?
We're affiliated with Cedars, yeah.
Awesome. And then so she went to school at Rutgers for undergraduate as well as medical school and did her residency at Cornell. So I'm going to let her talk a little bit about her training, and then we'll kind of dive into the questions about pain management today.
Hi, everyone. Thanks for having me. I'm Leia Rispoli, as said, and my training background is actually in physical medicine and rehab at Cornell in the city, New York City. And I did a pain medicine fellowship, an anesthesia-based pain medicine fellowship at Cornell as well. The reason I just think that is because a lot of pain doctors are anesthesia trained in residency, and there's a portion of them that are physical medicine and rehab trained, which has a little more experience working with rehab therapists at a more intimate level, which I think is somewhat of a benefit going into pain management as the ultimate field. So yeah, now I'm out on the West Coast practicing for Remedy Pain Solutions is the company I work for. Just one other colleague, my boss, Dr. Bajaj. We're in Marina Del Rey, and we serve a lot of the Santa Monica, Marina Del Rey, and some of the South Bay area. And we do a lot of mostly spine, peripheral joint, pain management, but being the female and very few female pain doctors have delved a lot into pelvic pain treatment. And that's kind of what we're going to talk about a little bit today.
Awesome. Yeah, we thank you for that, right? We don't really have as much of the female population treating pelvic pain and being able to talk about pelvic pain in general. I know we get a lot of that here at Women's Advantage where, we have patients come in and it's like they didn't know physical therapy for this existed, or there are other remedies for pain management in the pelvic realm. So I appreciate for you being here and having this conversation with us. I guess my first question is, what to expect during a consult with you. I think, a lot of patients go in thinking, okay, I'm going to see a doctor. They're going to take my blood pressure. They're going to ask me a couple questions and maybe take my heart rate, right? So just kind of, would you mind going over, what a consult really does look like coming in to see you?
Sure. Yeah, it's a good question. As you were just saying, it's a super underserved and underappreciated population. So, grateful for you guys too, because this, as you guys all probably know, it's a very complicated topic. Patients usually come in with quite an extensive, complicated history. So when I see a patient, I'd say 80 to 90% of the time, they're referred to me by either a gynecologist, a GI doctor, or hopefully a pelvic physical therapist. Most of these patients, if they have the courage and access and knowledge to even reach out to someone to help, they're usually referred to a physical therapist first, and hopefully a good qualified pelvic physical therapist, which is a benefit to me because I always require patients have seen a pelvic physical therapist before we do kind of any intervention or offer any kind of treatment algorithm typically. It's a complicated field, and the expertise and the intimate detailed exam and the intimate detailed work that pelvic physical therapists do with patients is a huge portion of what, affects what I do. So a typical visit would be a patient coming in, and most of the time they have a ton of imaging, a huge history, a really complicated and really disappointing background to share with me. So I usually spend a lot of time with these patients if they're new, just kind of hearing what they've been through, what they're going through, and a lot of it's listening. I'm sure you guys know it's a lot of just listening and validating that this pain is real and that they have reason to have it, and that we have some options to try treatment for. So that's like a huge hurdle to overcome, with the first visit, because patients usually come very desperate for someone to just hear them, especially a doctor, because they're finally a female, finally a pain doctor, finally somebody that knows what I'm experiencing and has experience in it. So, that's typically the first visit, a lot of listening, and then going over, what's been done treatment-wise, what's been worked up, if they've had imaging, if they've been seen by a therapist, if they've seen other doctors. And usually those are the typical base questions to get through. What's been done and what treatments have they had, and what kind of presentation they have, pain wise.
Awesome. That's good to know. So now if we talk about treatment algorithms for pelvic pain, right? Would you mind walking us through someone who that you see the most common, right? They've seen a gynecologist, they've seen a pelvic floor therapist, and they've had chronic pain for a year or two. How does that differ from someone who has had this pain for 3 months, who's a little bit more acute and just is at, again, mental and emotionally, like we know, at their wits' end?
Yeah, definitely. So yeah, they're both different scenarios. You know, being a more chronic pain treatment doctor, usually want them if it's acute, if anything, an event occurred, if they're postpartum or if they're pregnant. Obviously, it's very important that they've seen their obstetrician and they've seen if they have history of any kind of urological dysfunction. I usually have before also any kind of treatment algorithm going down the chronic pain route, make sure that they've been cleared by a full gyne, OB, if appropriate, urologic and GI workup by these other doctors to make sure there's nothing, because obviously these are systems that I don't specialize in, and I want to make sure there's nothing anatomically, worth going further into a workup that would be their territory, not mine.
Mhm.
So, check off those boxes for me is a huge, initial part of the consult with the physical therapist involved and all those other doctors I just mentioned. Um, in terms of treatment algorithm, again, depends on their history, medication wise, what they've tried, what they're on, if they've had side effects. A lot of times they have tried a million meds and have had side effects to every single one of them and don't want to try meds. Or the other end of the spectrum where they're on a ton of medications and they have all these sorts of side effects and hate it and don't have a way of weaning off of them. And that's a whole nother game to play, but that's important, part of the treatment algorithm too. I honestly, most of these patients are younger, and I honestly don't, love any younger patient being on a chronic med.
Mhm.
Obviously opiates we don't like. We don't even prescribe them at my facility. We just don't believe in them. But a lot of the neuropathic pain medications cause a lot of grogginess in patients and making them feel cloudy. So we try to manage all the side effects to all the different categories of meds to make sure that their quality of life is sustained. And then beyond that, I don't know if I'm going too much into your question, but um, you know, I do a lot of interventions, and that's kind of the base of my practice, both in spine and in pelvic pain. A lot of time, we use intervention, meaning injection therapies, to help us diagnose and kind of tease out some sources of pain. A common diagnosis that we see a lot, and patients get, sometimes overly labeled of, but is very common finding is pudendal neuralgia. So I'd say a majority of these patients, I do a lot of pudendal blocks. I do them image guided. So we use an X-ray fluoro guided. I also use ultrasound if I feel like it deserves more accuracy. So sometimes doing both images to really just confirm 100% that we're by the pudendal nerve because some anatomical variants. We do trigger point injections into the pelvic floor. I do a lot of Botox injections into the pelvic floor, and I found a lot of success. And again, and those are ultrasound guided too, which is great because we have one in the office.
Wow.
And just a side note is that a lot of these patients are very anxious and very hypersensitive. So we do have sedation offers, for options for patients to be able to, either be completely asleep on like something like propofol in an anesthesia, guided surgical center, or in our office we have something called Pronox, which is nitrous oxide, so they kind of feel out of it, like at the old school dentist office, and
Uh-huh.
it's cheap and it's something that makes them feel a little more comfortable while they get any kind of intervention. And then beyond that, so I mentioned the pudendal blocks. There's a variety of other sympathetic blocks, like the hypogastric blocks, lumbar sympathetic blocks, trigger point injections, Botox injections. Um, and yeah, so we do a variety of those interventions, depending on areas of pain and qualities of pain and patterns of pain. And now that I, talk about all this, it's so much of this is super collaborative with a physical therapist because as their doctor, I probably see them 1/10 of the times that you guys see
Yeah.
and evaluate and are treating these patients. So the therapists have such a much more intimate relationship, with the patient emotionally and physically. So you will see pre and post intervention way more than me. So it's, you know, a lot of the care and the algorithm that's constantly being adapted is dependent on the physical therapist evaluation. So being able to talk to you guys and, you know, exchange cell phone numbers and keep in touch about all this patient's, you know, care and how they do with interventions is a necessity. So, you know, I appreciate this type of kind of lecture because I love to meet all of you and be able to collaborate, you know, in care with these patients.
Definitely. So that's actually really good to hear because we've had a couple patients that we shared. Now, my question, I guess, comes down to depending on the type of intervention, whether it's a trigger point or a Botox or pudendal nerve block. I think I've treated the spectrum of that following an intervention. Do you have a grace period where we want to wait before they come back? Like I know with Botox, well, with all three of them, the sensation changes, right? The goal is that the pain threshold changes and diminishes. Now, my understanding is that once they get this procedure, they may feel good for the first week, 2 weeks, and the goal is that it lasts, right? Now, is there any precautions or treatment contraindications from a PT perspective that you would recommend or look out for? Because a lot of the
Yeah.
time we'll tell patients, like if you get a nerve block, there may be incidences of a little bit of incontinence just because it's the genitalia, right? So there is that. Anything else that you would think about or recommend?
Sure, definitely. You know, with nerve blocks and even trigger points, there's a local anesthetic used. So patients could sometimes experience either a numbing and that could feel great and short-lived, or that sometimes can feel very irritating to patients. So it's I usually say at least wait like a couple days to make sure they can recognize their response, whether it's good or bad, and that the physical therapist stays in touch with the patient as well as me to make sure that we try to maximize the benefit. So you know, every nerve block, every kind of intervention, injection therapy that I do, the goal, and you know, this is another point that I wanted to make is that, you know, really mapping out realistic expectations for patients. Like, what are we trying to do here? You know, a lot of them come so fixated on what's my diagnosis, and I need a name so I can Google it and research it and try to find a cure to it. So I kind of revamp that mindset and you know have them focus on your symptoms and how we get those symptoms reduced. Not completely gone, but how do we reduce it so that your quality of life is improved? And my role is really to make you know symptoms reduced enough to benefit more in physical therapy. Like there is no purpose of nerve block and Botox therapy, Botox treatment if there is no physical therapy. You know, I make that I really try to stress that to patients because you know people typically in a lot of pain look for quick fixes and an injection isn't going to it might quick fix it but literally just quick fix it and then pain returns and patients are like now what. So you know the whole goal of injection therapy is to make sure that there's benefit and more gains in physical therapy because a lot of times I'll get sent patients from pelvic physical therapists that are saying, you know, we've kind of hit like a threshold where she's too hypersensitive, she's too sensitized, we can't get anywhere. So let's try something that reduces the symptoms, even for temporary reasons, so that we can get a little bit more of a better evaluation and more gains in therapy. Um, so that's kind of what I try to educate the patient into and keep us all on the same page because I know that's a huge thing for you guys, I'm sure too, so that they don't have the mindset that they're going to go to a doctor and get something fixed and they're going to be cured and that's it, you know, because that's a dangerous mindset. So,
Yeah,
you know, disappointing.
definitely. We do definitely see that where, someone again is at their wit's end. I think that's the best way to describe it in pain, whether and they've been ridden with it for years on end. And so they want that quick fix, anything and everything, right? Like just quick, get it done with. I don't want to deal with it ever again. But again, having that conversation of, okay, well, the goal is, you see Dr. Rispoli or the pain doc, and the goal is to get things tempered down enough that we can make progress here, whether it is internal vaginal treatment for trigger points or pelvic floor coordination, understanding how to relax the pelvic floor and lengthen, as well as diminishing the central nervous system. I think that's one big thing we talk about here as well, kind of like the danger to self
Absolutely.
and the safety to self, right? Of if someone's having pain with penetration following trauma or anything of that nature, we always will talk about, okay, not necessarily addressing the trauma per se, right? Because that's out of my realm. I may send them to a therapist
Right.
or a counselor or something like that to have that conversation, but being able to just understand and have that conversation, then, you know, possibly sending them to you to desensitize a little bit so that they can come back here and
Yep,
we
yep.
can kind of work through the physical piece while they work through the emotional and mental piece with another provider, is kind of the multidisciplinary piece that we take here. Along with, again, like you
100%.
said, any of the other disciplines of like urology, OB, and anything of that nature to clear all those boxes. Um,
And mental
so
health is huge. These patients also, like if they have history of trauma or even just being in chronic pain is a traumatic experience. And validating that for patients, saying that like, yes, everything hurts and there's reason. We know that chronic pain becomes centralized and it's stored within the central nervous system. And your reactions to certain stimuli are going to be altered compared to the
yeah,
average person. So, patients just hearing that and knowing that it's like, it's true, it's real, what they feel, there's
yeah,
science behind it, is extraordinarily validating and rewarding, because you can see how much it means to them to be able to find somebody, a provider that can explain that to them and really, you know, talk them through that, and be able to say, there is a mental health component too. And really, like you said, multidisciplinary, being able to have several providers, healthcare, mental health, physical health, like on board, and talk about lifestyle and quality of life and diet and exercise, all those things, hearing it from all the providers is just super helpful in patients' outcome.
yeah, definitely agreed. So with that, do you mind going over a little bit of like the diagnostic tools, right? We had talked about the subjective, taking extensive medical history, subjective history, what's happened, what's been done. And so with the diagnostic tools, what would you do, and different treatment strategies for something that is nerve related versus more musculoskeletal? I think you've touched upon like the Botox versus a nerve block and different oral medications. Is there a expiration date on a Botox injection, right? I think a lot of the times we talk about like they'll get relief for up to 3 months, but if it diminishes, when do they come back to see you? Versus if it is a nerve block, when should they start to see some relief, and when does that nerve block maybe wear off? And all of those alterations to care.
Yeah, timeline is important because again, patients will want to know, is this one injection going to help me? And then what? What if it wears off? Which is something we see in chronic pain with spine related stuff all the time too. So we really focus on setting the bar pretty low, saying, this might help you temporarily, but it's really going to serve us a little bit of diagnostic evidence. If you get relief from the pudendal block, which has some steroid in it, which can provide a little bit more of a longer term benefit because of reducing inflammation at some level. If we get longer benefit from it, and can see that doing one of these every few months might provide enough benefit in physical therapy, then that's something that we can talk about repeating with patients. It's not my favorite thing to bring a patient in every 3 months to do a steroid injection. Eventually we're going to have to talk about some other longer term possibilities, treatments. But similar thing with Botox, I don't expect one treatment to be the quick fix with all these things. It's, again, it comes down to a collaborative type of, treatment with the therapist to see what more gains we can make in physical therapy. If we can get a little bit more of diagnostic evidence for patients that are too hypersensitized to get any kind of proper eval in therapy. One thing two things we can bring up that are become a little bit more of an open discussion for longer term benefit. If we do get temporary relief from steroid injections of the nerve or trigger points or Botox, etc., is two categories. There's regenerative medicine, and then there's stimulator. So one topic we wanted to talk about today was a stimulator device, which I found pretty successful in patients that have kind of exhausted everything else. I'm sure a lot of you have heard of something called interstim, which is a little different than what I do. Interstim is used by urologists, and it was initially designed for bladder incontinence. It's a little device that sits the sacral nerve roots, and it's permanently implanted. But urologists have been kind of exploring the use of this, initially designed incontinence device for pelvic pain. This is obviously a biased population because I've seen a lot of them come in to me and say it didn't work. Obviously, if it worked, they wouldn't be seeing me. So it's, it's a little bit of a biased or skewed perspective, but that device is placed by urologists. I don't place that. And I'm not sure how well it works. So it's not for me to really comment on, but what I do, if we've gotten to a place where we've had really good short-term success with something like a pudendal block, or even a sympathetic block, like a superior hypogastric block or a lumbar sympathetic block, we use a device called a spinal cord stimulator, which similar concept to the interstim. We use it, it's FDA approved for spinal stenosis. So we found a very good success with patients that we see a lot of the time with spine care. So we implant this device for similar reasons, patients that have failed surgery or have failed kind of all conservative care for spine issues. But when we use it in pelvic pain patients, the difference between this device and interstim is that we do a trial period. So we basically place the stimulator, which is the size, it's basically a string that's like a contact, has contacts on these titanium leads that sit next to the nerve roots of the spinal cord in the epidural space. So it's like doing an epidural, but instead of placing medication, you place a stim, the stim lead, and then we leave it in for 7 days. And then the patient then works with the representative from that company, teasing out location of the sensation and level of intensity. So sorry, there's a lot to this. So the stimulator, what it does basically is trick the pain sensory pathways to not feel pain. It's overridden by what these leads give off, a little bit of electric impulse. So it's similar concept to TENS unit, which dates back forever, except that instead of externally placed, it's internally placed. So it's the gate control theory, which you can look up, and it's like a super old concept that states that sensory pathways to the brain can really only be a one-way road. So if you block that with a slight paresthesia, the pain pathway has no way of getting there. So that's the most basic way of explaining how this device works. It gets a little bit more complicated because it's now been around for 15, 20 years. And then these companies are super competitive with each other. So they all have their own tweaks of other types of technology. And it's pretty advanced. It's pretty spectacular, the things that they've been able to research and discover what really goes into nerve pain. So that's a whole nother topic I'd love to discuss another time. But basically, I think the benefit to doing the spinal cord stimulator for these patients versus something like interstim is that they get the trial period. They don't get it permanently implanted. They get it temporarily placed. And that's done under propofol anesthesia. And it's placed set for 7 days, and the battery is just taped to them. So they can't shower, bathe around it, which is annoying. But for 7 days, they get to test this thing out and see if it really helps their chronic pain. And then evidence behind it, like what's been researched, is that it not only helps with the direct nerve pain and that sensory pathway, but there's something that happens at a more centralized level for patients that have been suffering for chronic pain that's now become centralized. So if they do find it successful, then we bring them in a few weeks later and then just place the battery underneath the skin. So it's just placed subcutaneously. So it's an hour-long procedure. It's not a surgery, but it is done under propofol. So they do have to do it under surgical center. But they recover that, that hour after, and then go home and then get the staples removed like 14 days later or so. So it's a relatively small procedure compared to something, super complicated and advanced, but it takes a lot of time to educate the patient and, explain to them, if they have fears about what it means to have a device in them and everything that's, involved with that. But we work with these companies that have very good educated representatives that help us kind of navigate that education part.
Yeah, we have a mutual patient that actually went and gotten that device from you, and she's seen good relief. And seeing her back, I think you and I were in conversation when we got to that point where you were like, we weren't getting anywhere, but the nerve block worked, so you did the trial. But having that conversation with you of like, okay, maybe give it, I think it was like 2 to 3 weeks before we work on any scar tissue, right? Because that's something we do here as well. With the battery implantation that is subcutaneous, there is an incision point, and talking about, okay, do we work on the scar tissue? And that's why that whole interdisciplinary care is so great, because I can be able to be like, okay, it's been 2 weeks, it kind of looks like this. Can I work on it? Should I back off? So that was a really kind of nice learning curve for myself to just be like, okay, where are we with this? But my question is, with the neurostimulator, that's what we'll call it, when you place the trial leads in, right? They're embedded, correct? And
Yep.
they're on the sacral nerve roots.
Yep.
Now, if it takes, you don't have to remove those, correct?
So you do actually, we remove it just because we usually give patients about a 2-week break after that
Okay.
to minimize infection and to kind of let things a little bit heal over.
Mhm,
The highest risk of doing the trial is infection. So we
mhm.
really paste it down on their back with like layers and layers
Yeah, I
of
remember that.
Tegaderm and all such. And that's kind of the protocol for this device is that you do a trial, you remove the lead 7 days later, sometimes earlier. Like if patients are having an incredible trial and they've had at least 3 or 4 days of great success where it's enough, where I can say, okay, it's obvious they're getting benefit from it. We can remove it early. And same goes if they're not getting any benefit at all. If it's like, okay, this thing is not helping at all and they want it out, take it out. And that's the fear factor for patients that are like, I don't know if I want this like permanently implanted in you. I'm like, well, you can try it. You can try it, and there's no real repercussion. We can just remove it, within the trial period, after you've kind of gotten some sort of result, and say goodbye to it if you never want to see it again. Or you may love it and it might be life changing. So, and they'll have the ability once they're trained in the device to have like the handheld remote to kind of adjust based on their pattern of what they're doing that day. If they're having a bad day, if they're having a good day, turning it off. It's
Mhm.
rechargeable. It's very easily rechargeable. Majority of these devices now are MRI compatible, so there's really not a lot of limitations for this device, and it's a good option for a long-term thing if the patient is appropriate, deemed appropriate for it.
Yeah, and then I guess going off of that, right? We've treated this patient, and she's come back, right, with with the neurostimulator in her. And the nice thing about the device is, you're right, she can turn it off, right, if we need to do any internal work, because I was feeling the tens through my finger. So she turned it
Wow.
off. We were able to work on it. And the nice thing is too, with you'll still have some trigger point stuff, well, because she still is active, right? When we talk about pelvic floor, it's a sub maximal contraction when we're sitting here talking, walking around, doing our daily lives, because if not, we'd have a lot of leakage or whatever it may be. So having that in conjunction to what we do here with like whether it's biofeedback to kind of help coordinate the pelvic floor, understand how your breath is regulated through all of that has been actually really helpful and eye-opening from a therapist perspective. I guess the other question that has come up with the neuromodulator is there a revision that needs to happen within 10 years? Is it kind of where is that in terms
Yeah.
of care?
So good questions, and it's still a relatively in what's considered like new in medicine. It's still, it's been around for a bit, but I'd still consider it new. It's still a heavily studied. It's criticized by some, like the surgeons don't love it. In use in some realms. Sometimes people say it's overutilized, so you got to be really careful about, at least from a pain doctor's perspective, about choosing the right patient for this device and not just kind of offering it to everyone. Um, and then making sure that they know, yes, that the battery life for a majority of these are 10 years. So it will need a battery replacement in 10 years, but that's a very easy thing done as long as the leads can be proved on x-ray. They're still in the same right place, and they're still getting relief. The battery pocket is just open, battery replaced, and it takes 20 minutes under propofol. So it's really easily done. And some patients will say, well, what if I don't like it anymore? What if it stops working? And that is a possibility. And those are some of the longer term studies that are still, the jury's still out whether or not, how long does this device really last for? If they get relief for a few years, if it really is a lifetime thing that really makes patients feel significantly better for a majority of their life, then, you know, um, it's something that, make sure patients know that if they don't like it, it can be completely removed. And that's another procedure, but it's a device that can be taken out faster than it is placed in. So that's
That's
always an
always good
option.
to
And
know.
it doesn't change anything anatomically, it's just removed. So yeah, I want to think if there's anything else I wanted to touch on that about. Um, but
Were there any limitations
yeah,
to placement of the leads? I think there's a little bit of scare too with a couple conversations when I kind of bring this topic up and refer people over is, well, is there any issues when I move funny, if I sit, if I slouch, or if I put too much weight through like my sacrum or whatever it may be, like will it um alter where the leads sit? And where is that? And scar tissue, right? I think there's a lot of conversation about scar
Yeah,
tissue.
that's the biggest rate of that's the biggest complication that can come with this device. The leads, once we do a trial, we try to replicate that with a permanent and then actually anchor them down into ligament. Um, that should, if it's done properly, should be secure enough so those leads do not move. But of course, that's the one thing that kind of happens most commonly for the device to stop working. It can easily be evaluated by taking an x-ray, say, oh, that lead did move. And hopefully, it didn't move enough to really change the clinical outcome for the patient. But it's definitely something you have to educate the patient in the first couple months while scar tissue is still being laid down, to really even further secure where the leads are placed, to kind of limit overflexion, overextension, any kind of like extreme sport activity. But that just comes with the education part of it.
Okay, that's good to know. I guess lastly, too, going back to something everybody's a little bit more familiar with is oral medication, right? I think there's been kind of talk about what's been tried, what hasn't been. I guess for you in your clinic and in your care, what is the first line of defense to try that is generally more across the board compared to
Yeah.
dialing it down to more specifics?
Sure, those good questions. As I said, oral medications, depending on the age, and then if the patient's still working and still has a quality of life, I think it's important that they know the potential side effects. So
Mhm.
the really easy medication to start patients on, and they usually already come to me on or have tried and failed, is gabapentin or Lyrica. They're common neuropathic medications. They're relatively safe with a small side effect profile. They're easily titratable, so you can start at a really low dose and work your way up. I'd say 50% of patients find it way too sedating to be on during the day. So sometimes patients are just on it at night. Some patients find gabapentin better than Lyrica, sometimes vice versa. There's other neuropathic medications that can be used that have their own kind of side effect profile, kind of like amitriptyline or triptyline, that class category of medication. There's also something that we've been using a little bit more of, which is an interesting topic for another lecture, is low dose naltrexone. We know of naltrexone as an antagonist to the opiate receptor. At low doses, it's been studied to be really helpful in chronic pain patients, and even in specifically in the pelvic pain patient population. So that's another thing and it's a very small side effect profile also. It's a very safe drug. It's very cheap. It needs to be made at a compound pharmacy, but it's been something I've been kind of incorporating a little more. Now patients can't be on opiates if they're on it, obviously.
Yeah.
But most patients aren't, on a level of opiates that, I see at least, where that's not an option. But again, like most patients come to me and are like, I do not want to be on meds. So it sort of makes it harder and easier in a sense where it kind of narrows down our treatment options, but also it can take away from some alternatives or some when I tell patients that it's not usually just one thing that we do that will help. It's a combination of meds, physical therapy, and injections that will probably get you to a better quality of life. But it's all dependent on the patient and their willingness to try things, and then their ability to tolerate medications. One thing I wanted to touch upon that I don't want to forget to mention, as an alternative to the stimulator, as a more of a longer term, bigger picture, what do we do if this works only temporarily kind of option? Because the stimulator is covered by insurance. So that's always a factor for patients. Like if I'm paying out of pocket for this, what are the costs, and is insurance going to cover it? Because that's a level of frustration and stress and anxiety for these patients also. One other option we do have, but it isn't typically covered by insurance, so I have to tell patients that very upfront, is regenerative medicine. I'm sure you guys have heard of like platelet-rich plasma, PRP, stem cell therapy, or what we don't even call it stem cell therapy anymore because of how it's been displayed in media, but bone marrow aspirate concentration is what we call it, BMAC. And then something else that's kind of newer that I've been using very successfully is called alpha-2 macroglobulin. It's sourced from patients' whole blood again. So all they do, similar to PRP, is get a blood draw in our office. And then we use our centrifuges and then our extraction devices to get a layer of plasma that has an alpha-2 macroglobulin enzyme in it that's been, really studied as a form of using your own body source to reduce levels of chronic inflammation. So PRP, platelet-rich plasma, is sourced from the blood also, and that's used to regenerate or kind of rebuild tissue or heal what we call neural tissue, or it's been used a lot in tendon therapy, or tendinopathy, sorry. So that's where most of the evidence is for PRP, Achilles, lateral epicondylitis, but we've used it successfully, both platelet-rich plasma and alpha-2 macroglobulin in different settings for chronic pain patients. Now, as I mentioned, that's not covered by insurance, so there is a out-of-pocket cost, but for patients that want to keep it natural, that don't want a device in their body, we've seen pretty good long-term outcomes with these type of treatments.
Yeah, I've actually heard of that. And I know about Dr. Bajaj's office where you work, you guys do a lot of the PRP injections for different parts of the body and the spine. Now, when it comes to pelvic pain, right, is it done again via under ultrasound, under x-ray? Like what kind of, how is that played into the care and where is it placed?
It's always done under imaging, because especially if they're paying out of pocket, we want to ensure the accuracy of where the regenerative injection is being placed. Also, since it is out of pocket expense, it's usually beneficial to do a diagnostic injection first. So I will do, if patients like, I only want to do regenerative medicine treatments, I'll say let's do a lidocaine injection first at, for instance, the pudendal nerve, to make sure that it definitely covers your area of pain, so that when we do the next step, which is PRP or alpha-2 macroglobulin, we'll know that we're hitting the right source. It's the source of your pain, because diagnostically we discovered with lidocaine injection you had relief.
Got it. Now, when we talk about pudendal neuralgia,
So we'll take a two-step process.
Out of curiosity, did I lose you? There we are. When we talk about pudendal neuralgia, my curiosity is also, in your office, do you look at 3 different branches of the pudendal nerve, depending on where their pain is, or do we kind of hit the root of pudendal closer to where the sacral nerves come through?
Yeah, so it's a good question. A lot of people ask that. I think I've had a lot more success where, the Alcox canal, like, hitting the source of the pudendal nerve is so much more successful. It can create more numbness or strange sensation temporarily in maybe areas patient didn't have issues, but the coverage is just so much more, it's just more vast. And it's just like, in my opinion, it's more accurate to be able to hit that target instead of try to target one of the small branches, and patients just find it more successful.
Yeah, I could see that, because again, right, why go through 3 separate times of injections? Because they're
Yeah, unless you're looking for something for very, very specific type of entrapment, which is a completely different category of patients. Which, if a surgeon had sent a patient to me saying, let's do a branch diagnostic block to see if that particular branch is being compressed or has an issue, because it might dictate their procedure, moving forward if they were to do something surgical. But other than that scenario, I don't really see a benefit in being so much more specific.
got it.
And patients sometimes come in and they fixate on something so detail, like so particular and specific, and I try to explain to them that it's more about getting relief for you than having like a very specific this branch is irritated, and let's treat the level above it, and then be able to get more result. Because if by chance that's more than one branch, we're going to face a little bit more of an accurate result.
Gotcha. Now, for the PRP and the alpha-2 globulin, how do you differentiate which one to use for what diagnosis? Is it based upon, I know we talked about the diagnostic tool of like using the lidocaine to see if it works, but how do you decide on which one you're going to use? And do the patients get, whether it's a say or an option as to they want one or the other? Because I know we all have patients that have preferences.
Yeah.
And I think PRP is the one that's in the news, that's been around for a lot longer, with more exposure. So how does that change when they see you?
So PRP, there's definitely more evidence in the PRP realm, but the evidence really isn't strong for anything other than tendinopathies. So, it's really, what we know is PRP can work for Achilles tendon issues, lateral epicondyle issues, and other general tendinopathies. But outside of that, I haven't seen a lot of success with PRP in terms of neural tissue kind of healing.
Got it.
I've been using alpha-2 macroglobulin a lot, to be on a lot more recently for even stenosis patients that have either failed surgery. So like the lumbar, patients that come to me, lumbar, cervical, any of them, that have a significant level of foraminal stenosis, where there's mechanical compression, have a chronic inflammation state around the nerve. So when you inject and bathe the nerve in something that's more anti-inflammatory, like the alpha-2 macroglobulin, I've seen much longer, more powerful results. So I've been using that more in the pudendal neuralgia patients too, because the theory is that the pudendal nerve is irritated, it's inflamed, and something keeps irritating it, whether it's mechanical, whether it's just a chronic inflammation state. But the alpha-2 macroglobulin it's not aimed like PRP to heal, it's more just to kind of halt the inflammation cycle and be able to have some relief around the nerve tissue rather than heal it, because it's not necessarily damaged, and that is all theoretical. There's not like
Irritated
science
more so than it is damaged.
Yeah, exactly.
Okay. Now, do you find, so LDN, we actually just had a pharmacist come through and give us a talk about it. And it seems like it's been around, but I think in the past, however long it's been, it's kind of becoming a little bit more talked about, right? Now, do you use that in conjunction with the other therapies that you have spoken about today for a more long-term effect for patients?
Definitely. They're not mutually exclusive, so it's more about kind of delving into what the patient's comfortable with and what, based on their presentation seems most appropriate. LDN is probably one of the drugs that I would feel more comfortable patients on being long-term, without a side effect profile, compared to something even as benign as gabapentin and Lyrica. So it's new, and I'm, to be honest, I'm just starting to incorporate it more in my practice. So, I'll let you know in the year, probably be more results. But so far I've had a handful of patients that have said it's been very, very helpful for them with no side effects. So, that's the ideal, right?
Yeah, definitely. And then any preferences as to whether it is oral versus topical versus anything of that nature?
Oral, it's usually like a small pill that's compounded at a pharmacy. For topical, in the genital area, it's a little bit more complicated just because, a lot of time there's other issues going on too that the gynecologist or urologist might be also treating at the same time, whether it be a hormonal issue and tissue related. So I try to kind of keep my territory to injections and oral medications, but it's also a conversation to be had if necessary with the other treatment providers.
Okay, well, thank you so much for your time today.
Yeah, of
Congratulations
course.
again. Thank you so much for time for
Thank
taking
you.
out that hour and
Yeah,
having this
thank
conversation
you.
with us. I've learned a lot. But we will definitely post Dr. Leia Rispoli's information on our webpage, and kind of if you have any
Text
questions,
me, email me, anytime, anyone.
we'll
Yeah,
do.
I'd love to meet all of you one day. It's a little bit safer and I'm
Right.
not on maternity leave, but I'd love to have any more of these conversations with more detail if there's any questions. And
Definitely.
likewise, if we share patients, I'm like all about texting you guys and then being able to keep in touch and collaborate all the time about the treatment care.
Yeah, we've definitely had great successes with that. So I again thank you so much for taking out the time and doing what you do.
Yeah.
And then we will kind of go from there. So if anybody has any questions, leave us a message on our Facebook page or Instagram. Give us a call, and we will have Dr. Rispoli's information posted as well. And then we'll go from there. Thank you again.
Thank you guys. Take care
Bye.
now. Bye-bye.